Hello, good afternoon, everybody. I am Emanuele Neri, President of the European Society of Medical Imaging Informatics. This webinar is the 9th webinar of the Society and is kindly sponsored by the National Decision Support Company. The National Decision Support Company Europe has been founded in 2015 in Vienna, and is a full subsidiary of the National Decision Support Company of the USA. The company provides EISRE iGuide, a clinical decision support tool that contains the urology imaging referral guidelines. The company provides a platform, contracting, and integration service to transparently integrate EISRE iGuide within other entry workflow, so up-to-date guidelines are available to referring doctors at the point of care. EISRE develops in stricter contact with the National Decision Support Company, develops and maintains evidence-based criteria using radiology and user input. So the motto, the aim of the National Decision Support Company is less unnecessary images, better patient safety, and more efficient healthcare. So on behalf of EUSOMI, I would like to thank National Decision Support Company for supporting this webinar. Today's webinar is presented by Professor Lluis Donoso. Professor Donoso is the Radiology Immediate Vice President. He is Director of the Diagnostic Imaging Department at the Hospital Clínic Barcelona at the University of Barcelona, Spain. He is the Executive Director of UDAP's Center Diagnostic. He has been Vice President of the Spanish Society for Diagnostic Radiology, CERNER, from 1998 to 2002, and President from 2002 to 2006. In 2014, has been Secretary General of the International Society of Radiology, and since 2000, he has served the European Society of Radiology in various capacities. He is currently the EISRE Immediate Vice President and is President of the Spanish Foundation of Radiology. Professor Donoso has received many awards. We would like just to highlight the Gold Medal of the Spanish Society of Radiology, the Honorary Fellowship of the American College of Radiology, and the Honorary Memberships of various society around the world, as you can see in the list in the right corner. So today webinar is about the implementation. So it's a success story in implementation of a clinical decision support system. So please, Professor Donoso, you are welcome, and now it's time to start your lecture. Thank you.
Thank you very much, Emanuele, for inviting me for this webinar. I have to say it's my first experience using this system. It looks very promising. My intention in the next 35-40 minutes is to let you know about the last developments and why the EISRE has get into this field of referral guidelines used through a clinical decision support tool. First of all, I have to say that the clinical decision support system has been used for many, many years in different fields, from military to economics, stock markets, and in other fields in medicine. And basically is trying to get concepts from a knowledge base and to link these concepts to a database, and then using this inference engines to let into the decision support system. In our case, the knowledge base are the referral guidelines, and the databases that we are using are the ones in the radiological information systems, hospital information systems, electronic patient records, health records. And through this inference engine, we get the tool of the clinical decision support. I have to say here that to implement and to use a clinical decision support tool in our field, this has to be done mainly through a computed physician order entry. electronic one. So this can be used through a portal, as I will show you later on. But for being fully useful, has to be integrated in a clinical physician order entry, electronic one. And for being also useful, this has to be used at the point of care and to have immediate response. So this system is implemented to be used by the referral physician, the one that's asking for examination, in our case, requesting examination for our friends in America, or an examination, and he or she has to have an immediate feedback about the appropriateness of the examination he's asking for. Why the society, the EISRE, gets into this process? Well, coming back to 2013, the European Commission asked our society through a tender to get information through a survey about the availability of imaging and referral guidelines in Europe, and about the use of these guidelines through Europe. When in this case, I'm referring to the European Union. We saw with this work and with this survey that the availability of imaging guidelines in Europe is about 70% of the countries. Only the UK and France has fully developed guidelines, and others just adapted the ones existing to the national countries. But the most important figure is that nowhere these guidelines were used in the real clinical practice. As I well remember, if I well remember, it was about 7 to 8% UK that where the use of these guidelines was the most important one. But in the other countries in Europe, from Germany, Italy, Spain, Nordic countries, no one, or nearly no one was, or the referrals was using these guidelines. Additionally to that, the European Commission, through the European Parliament, passed a directive, the European Basic Safety Standards Directive, in 2013, and this will be applicable quite soon, in February 2018, where in this one of these standards, basic safety standards, it mandates that the guidelines availability has to be available to all of the member states. In terms, the directive deals with justification, optimization, and other fields, but regarding justification of examinations, is going to be obliged to have this guideline availability for all of the member states. At the same time that we were discussing at the European level, our friends of the American College of Radiology, they were lobbying the Congress in the US in order to get a bill passed there for the use of the appropriateness criteria in the United States. This bill was passed, as I said, at the American Congress, at the US Congress, and that means that probably, I have to say probably, because it was supposed to be January 2017, but at the end, most probably it's going to be 2018. All of the high-tech examinations, for high-tech, I mean CT, MR, PET-CT, PET-MR, to be reimbursed for Medicaid and Medicare has to be, will have to pass a CDS, clinical decision support system to get the approval. So, from the EISRE point of view, we tried at the beginning to merge, to get an agreement with them, our friends at the Royal College of Radiology and the French Society of Radiology, in order to explore, to merge the existing guidelines here in Europe. We had a pilot, we worked on that, and we finally decided that it was not really feasible because the level of the discrepancies and the complication on fixing and updating these discrepancies between both guidelines, the one from UK and the one from France. It was not related most of the times about the evidence base. It was related sometimes about the indication of, in particular, clinical scenarios. For instance, talking about stroke, in the Royal College of Radiology's guidelines, it was suggested as a first examination, the CT scan, and at the French Society of Radiology guidelines, it was MR. So both of them are indicated in this case, but depending on the clinical setting, probably this can differ. So finally, we decided, because of our good relation with the American College of Radiology, to have a partnership with them in order to use at the EISRE level the appropriateness criteria from the ACR, and we get an agreement to Europeanize these guidelines. I will be more. We will give you more information later on in this talk. So at this time, we also did a request for proposals at the EISRE in order to have a company to work with us in the development of the clinical decision support tool. And National Decision Support Company, the one that was working with ACR, emerged as the only viable platform provider. So at the end, EISRE and NDSC developed the EISRE concept using the EISRE imaging guidelines based on the ACR appropriateness criteria. So for you to have it more clear picture what is what here, in 2012, the American College and NDSC get this agreement where the ACR is taking care of the contents through the appropriateness criteria, and NDSC is taking care of the licensing, platform support, and they created the ACR Select product, which is the one that is distributed in US. In our case, through these connections, these agreements, together with the EISRE and the ACR, we get an agreement regarding the contents and how to develop the contents in the future. And then the DSC, in our case, has the same role that has in US, licensing and working on the platform and the support and the integration of the solution in different hospitals, regional governments, institutions, etc. And we have exactly the same that US is the ACR Select product. We have here in Europe the EISRE iGuide product. So the roles and responsibilities here in Europe is NDSC distributes and supports the EISRE iGuide in the EMEA market, means Europe in the WHO definition. It's not only European Union. Then for the EISRE, the responsibility is to maintain and to extend the content base on the market feedback and the practical experience and local requirements in different countries and settings in Europe. And the EISRE and the ACR, we share together a commitment to develop a common set of global imaging referring guidelines in the future. So the idea is to the EISRE and the ACR to update the contents, then to have this market feedback from the users through the EISRE iGuide product, then to use this experience in order to improve the level of the contents, and then to provide new releases through the company, through this platform of the EISRE iGuide. So the idea is to have to use the feedback of our users in order to improve the guidelines. Well, at getting into the system, into the application, it was our friends from the MGH, so the Massachusetts General Hospital in Boston. They started very early it was 2003, 2004, in transforming existing guidelines into a CDS system. Here in this screen, you have the ACR appropriateness criteria, their convention in the clinical decision support tool that is used at the MGH. When a referral is asking for examination, you have to click on the examination, and he or she has an immediate feedback, which is rated in 9 levels, where 1, 2, 3 red means low utility, 4, 5, 6 means marginal utility, and 7, 8, and 9 indicative examinations. And they have also an alternative procedures to consider, and this is where the system of the ACR Select and the EISRE Guide comes from. A few words on the ACR promise criteria, why we decided to go to adapting the promise criteria. The American College of Radiology started in 1993. They have expended a huge amount of resources in terms of dollars and in terms of time of our colleagues in America. They have more than 100 people involved in the different chapters of the criteria. About 27 medical specialty societies has endorsed this criteria. Here you have a list of the different subspecialty societies and specialty societies that have been contributing in the last years. And as you can see here, we have more than 6,000 peer-reviewed published articles with the CPT codes. They have described 3,000 discrete clinical scenarios and closer to 15,000 clinical endpoints. So this means that when we had our discussions at the ESR level, don't seem logical trying to reproduce all of this experience at the ESR level, and that's why we decided to go together with the ACR from the very beginning. But saying that, we very soon realized that this, the promise criteria of the ACR in most of the cases apply perfectly with our scenario scheme in Europe, but in sometimes this is not the case. That's why we set up a group of ESR experts in November 2014, overseen by a methodologist who is Miriam Henning from Rotterdam. She is a radiologist and epidemiologist and has the best of reputations in this field. And we decided to adapt the ACR promise criteria into the European standards of practice, incorporating evidence for the latest European studies. So the idea for us is to have a generic European imaging referral guidelines to provide a common core of standard across Europe. And we know from the very beginning that this needs to be localized on national and institutional basis when implementing the system. We very soon realized that it's not enough a cycle of 2 years of renewal on updating of the existing guidelines. So when more people is going to be using the system, this guidelines has to have the possibility to be updated more rapidly. That's why the ACR created a rapid response committee in order to answer burning questions regarding different changes in the guidelines. And we decided to join this rapid response committee. It was decided to join from May 2016. And at the same time, last ECR, just a few weeks ago, we decided to create a formal institutional working group at the European Society of Radiology under the umbrella of the Quality and Safety Institutional Committee, which is called the EISRE Guideline Working Group. The results for the first round of the European review, that it was done early 2015, here you have these figures. It was, if we look at women's imaging, urologic imaging, gastrointestinal, chest imaging, breast imaging, and musculoskeletal imaging, it was quite good. So this is a kind of disagreement that we have with the appropriateness criteria that can be managed very easily. But in neurovascular was a bit more, and in cardiac, with about 28% of discrepancies with our experts to the existing ACR appropriateness criteria in cardiac imaging, was really unacceptable. So we very soon get in contact with our fellows at the American College of Radiology, and for them was the reason explanation for that is they were very close to do the last update on the guidelines, and because in cardiac imaging the facts are developing very rapidly, one of the explanations, apart from others, is that this updating was necessary, and we most probably will have a much lower level of discrepancies between the European and American guidelines. Here you have a screenshot that how the basic transactional workflow of the tool when you go through the portal. So it's not very difficult. You can go through a modality. Here you have the list of modalities. You can ask an examination for a modality, or you can go from the indication point of view. If you put in the system, in the search, in this case, ataxia, you have the clinical scenarios related with ataxia. You click one of them, and you have an immediate feedback when the referrals has an immediate feedback about if you're asking a CT scan of the head for ataxia, saying that the CT head, in this case, is not the best election, that because far below the MR in this case is the most indicated examination. And here in this link that you have down in the screen, if you click this screen, you have a direct connection, direct link with the appropriateness criteria, in this case for ataxia, in the PDF format. But as I said, this is not the best way to use the system. The best way is to have it integrated in an information system. I will show you some screenshots for the ACR select integration in a CERNER EMR. With the first example, we will ask for examination. We will request for examination on the modality-driven workflow. Here we have the screen with the patient. We just click to ask for examination. In this case, we would like to have a CT scan with contrast. Then immediately the system, the ACR tool select integrated in the system is open, and here you have it. It's exactly the same in the portal. Is in the case the system, the reason for examination is an ataxia. You have the different clinical scenarios related with ataxia. You have to just ask for one of them, and then here you have, as the same example as in the portal. If you were asking for a CT examination for this particular patient, MR is the one that we are supposed to order. Always in the system is helping the referral in terms of probability for he or for she to do the right decision, but is not taking a decision for them. So the one who's taking the decision at the end is the referral. In this case, because he was ordering a CT of the head, and the procedure that is recommended by the CSIS and MR, he can comment on that, and can confirm the change or not confirming the change, just going for the request for examination of the CT. The second possibility, which I think is probably the most interesting, at least for me, is going through the indication-driven workflow. As is the same system, here you have the list of the patients. Then you just have to choose an area of the body, in this case, neuro. Then we have here the reason for examination, in this case, the ataxia, and you will have to click on the specific clinical condition, and you have exactly the same list of the suggested examination, in this case MR, different types of MR, and then CT scan in the second level, in the yellow part, the marginal benefit. Here you can see that you have also an idea about the cost. This can be added or not in the system. We don't use this. And then you have also the level of radiation of the examinations in each one of the possible examinations. Then if you decide to confirm this request, you just have to click yes, and that's it. So the most interesting thing using this clinical decision support is every single request order is tracked in the system, so you can have information about who is doing what. You can compare between doctors between pairs. We just then pay attention on the ones that are asking for non-appropriate examinations. Then you can set up a system just to improve the performance of the different doctors. And it's well known in the literature that referrals or even doctors using clinical decision support tools, when they know that someone is looking at their decisions, is why they are really effective. So for an implementation of a clinical decision support tool has to be mandatory and has to be used for everyone in the organization. Then from the ESR and the ACR point of view, we get this information from the use of the system, which record the data, the age, gender, clinical indication, the properties scores, the modality, but without storing any kind of patient information in order to provide us feedback about the use of the system. And this provides this kind of analytics. There are many others about the order properties report that you can see there, and the CDS impact report, whether the doctors or the referrals has decided to proceed with the examination that was suggested, just to change it, or in some cases just not to pay attention on the advice of the clinical decision support tool. From the ESR point of view, this 2016 is the year to start working in different pilot testing. So we have a lot of different institutions and different countries interested in getting pilots from different countries, from Belgium to United Kingdom, Netherlands, Spain in our case, Russia, Ireland, Italy, and others. And here you see the different phases for the integration pilot process, which is preparatory phase and the scope definition. When you're using other language, translation is mandatory, and you have to integrate and test the system and to integrate it in the information system. Then it's important to map all of the organization procedures into the ESR content, which is mandatory. Very, very, very important is to test and change management. This is the most important thing. And then to have the evaluation. We started in our institution in Barcelona the implementation of the ACR Select 2014. And this is some of the things I personally learned. I will be a bit deeper on the process that we have to take into account when implementing a CDS. So this has to be a hospital project. This is not an imaging department project. We have to lead that. We have to be there in the forefront. We have to try to convince our colleagues and our referrals. But this, for me, has to be very clear from the very beginning that this is an institutional project, and the CEO, the highest level of the decision-making process of the hospital, has to be involved. Another very important thing is especially the referrals or representatives of the referral has to be involved from the very beginning. Even designing the integration with the information system, they have to be there for the first moment. Of course, the cooperation of IT providers and IT department is mandatory. Then translation, review, and necessary localization of referral guidelines is essential for the adoption. And this Translation is not a big deal, it's easy to do, but the review and the localization has to be done with the referrals and with the institutional responsive medical direction and the responsibility of the institution. And then, depending on the situation, for instance, in our case here in Catalonia, that the regional government is very interested. If you include them in the very beginning of the process, local and regional authorities, regulators, health ministers, it's also very important for the progress of the project and the implementation of the CDS. About the results, these are the results that were published in 2009 in radiology by our colleagues in the Massachusetts General Hospital. Here you have in this chart the years. The blue line describes where the implementation of the CDS. This is a study made from 2000 to 2007, and 2007 was about 60–70% implementation of the Mass General. Nowadays it's 100%. And in the red dots you have the growth rate in the last years. It was about 12%, and the adjusted growth rate when using the clinical decision support, which is very clear that it was a clear and a significant diminish in the number, not diminish in the growth rate. So this was very clear, it was useful, and we all assume that the referrals are asking for less examinations than expected because they are asking for better and for more appropriate examinations. Similar results were seen at the statewide study in Minnesota. It was published in 2012, and here you see in this graph exactly the same trend. In the blue line, you have the actual utilization. In the red is the projected utilization based on the previous growth rates, and different events that were influencing, especially the CDS implementation on the yellow, and the projection was quite compliant with the actual utilization since 2007, 8, 9, and 10. So it seems to be clear that when using the CDS systems, the implementation of the CDS systems diminishes the growth rate of the examinations. And as I said, I assume this is because they are using better the system. What about our project here in Barcelona? So, as I said, we had this project to be implemented in 6 months. We started with a strategy definition. And this is, I have to say, very easy because the CEO and the officers in our institution were from the very beginning very easy to convince them about the implementation of the CDS system. But I have to say, not only for radiology, I thinking also to implement in for lab and for other kind of situations in the hospital. We last only weeks in terms of integration of the system in our ordering system. We decided to start, I have to say, with our GPs. The hospital has a small piece of primary care for the population close to the hospital. This means 80 GPs within a specific information system. And we decided in our pilot to start with the GPs. So that's why it was not very difficult. The integration, as I said, with the information system. The translation was made by assistants in our department, and they did it in a couple of weeks. Then we map all of the procedures that we have in the system together with ones existing in this case was the ACR select. So the technicalities and implementation was not really a problem. The problem was to convince the GPs to be very early in the process integrated in the project. So I took I don't say more than, between 10 and 20 meetings with them. We finally convinced them. We try to find a win-win situation because the GPs in our hospital, they are not allowed, because they have a constriction in the budget in order to ask for high-tech examination. So we convinced the leadership in the hospital for them to ask whatever needed. And another concern for them was that the implementation in the ordinance system, that they probably will take more time in order to in terms of requesting examinations, and we'll refine and fine-tune the system. I will show you a screenshot, and at the end they are taking less time using the system, getting in the former format the way they had to text about the clinical information. But as I said, we took more than 6 months in order to convince them to get into the process. This is the screenshot of the ordinance system that we have for the primary care doctors. We have in the same screen going from localization. We have in your left different localization, and then the techniques in the lower. We have exactly the same things to find trying to find the indication. We have the clinical scenarios, and we have the feedback, and then they are allowed to ask for examination in the greens or in the yellows or whatever they needed. If they ask our referrals, an examination is not the most highly rated, then as in Boston, this screen, this pop-up appears, and for you to translate it from the Spanish to English, this is saying that I'm asking an examination with a lower score because the others, the one has in the highest rate, it took too much time. There is a waiting list because recommended by the specialist, because it was recommended by a radiologist, or because it was the patient asking for this examination, or for other reason, and they can type it in. They can text it in the system. Here you have the results for the first evaluation we did. It was quite similar for the one in the US, that our GPs were close to 90% in terms of appropriateness of the examination we're asking for. They had about 6% of marginal benefit and about 5% of log utility. The most interesting figure that we get here is we get about 20% increase on MRI request. This was not surprising for me because, as I said, they had a restricted budget for MRI, and now we are evaluating in the whole process when a patient is going, for instance, with a knee pain to the GP, and the GP in the last system were sending him to the specialist, and then the specialist to ask for examination to us, and then for us to send examination to the specialist, and then the patient back to the GP. If the examination is normal, which is very, very easy to understand, and the GP is asking for us for the MR for a knee pain in a particular patient, and it's normal, then the process can be finished. And we will have the results very soon, that we can prove that with this system, the patient has to need less specialist visits than it was without the CDS system before. So apart from the classical advantages of having more indicated and more appropriate examinations, we can have other benefits that we can explore in the different settings. So yeah, just finishing the timeline for us, as I said, it was in 2013, the European Commission study for the referrals. Then we get an agreement in March 2014 with American College and NDSC for creating the EISRE guide. We start in 2014 with Europeanization. We launch a demo in ECR 2015. We finalized the second round of the review of the content in 2015. Then NDSC was established in October 15 in Europe. We started the working group last ECR. American College of Radiology with the rapid response group. And we are very enthusiastically promoting the pilot testing in Europe, in the different European countries, in order to have more information and to learn about the different settings and different possibilities of the system. The benefits for me are quite clear. The improvement of the properties in medical image referrals, only this thing in terms of when you think about justification, it's worth to install the system, because we can demonstrate that we are doing exactly only the necessary examinations. It's a way to diminish the radiation exposure. The most reliable justification process in Europe is going to be a very important thing. Then I can see some advantages. I don't have time. How do we see from the radiological department how to deal with the green ones in the clinical workflow and in our department workflow? It's clear for educational benefits. We're working instead of we have now the EISRE guide version. We want to have soon the EISRE from education guide to be used at the medical schools. And in some cases here in Europe, we can demonstrate the lack of equipment, and it's a good tool to demonstrate the need for new equipment in several parts of Europe that don't have this the full technology they are supposed to have. So thank you very much. It's 18:46. I lost a couple of more minutes than I expected. I will be happy to take questions from all of you. Thank you.
Thank you very much, Luis, for the lecture, very clear lecture. I would like to. I see that there is already one question from Eric, of the members of the board of the Usomi Society. Eric is asking if is it difficult to motivate clinicians to use this software? Luis.
Well, in my experience, it was difficult, but the difficulty means that you have to see, and they have to see an advantage in using the system, whatever it is. So for us, for the GPs, was they want to have more visibility in the system. They want to have the possibility to ask for any kind of examination with any kind of restriction. And when ordering the system, this is going to be faster. Okay. In other environments, like we are now trying to get into the hospital in different departments, we talk about different protocols that we can use the system for the members of the department or even multidisciplinary teams to work together in a protocol to help them and to have the compliance with the protocol. This can also be very helpful. So you have to work with the referrals, with the clinical scenarios, and the clinic and the hospital management in order to find a good way. And this has to be done in any particular institution.
Yeah, and this is yeah.
Another thing that we did with our GPs, because they don't need the whole thing, so they don't need to have the whole clinical scenarios. So we refine the system for them to see only the kind of clinical scenarios they are usually using the most. So the fine-tuning together with them is also very important.
Okay, and this is the reason why this project should be an hospital-driven project now, because radiology has not the power to carry on such a huge effort.
Yeah, that's clear for me. Yes.
Yeah. The question from Eric, and the question is: do you expect that cost savings can be made in general or in the hospital?
Well, that's what we are trying to prove. Because if you diminish number of examination in a situation like in ours, that with this we work in capitation in budgets, so we are not fee for service. The less examinations you are doing, the best for the hospital. This is one thing. Second thing, if we can prove that we will need less visits from a specialist for a particular clinical condition, this in our environment, I'm sure they will also save. But we have to prove that.
Okay, there is another, funny question from Salvatore Sgroi from Verona. The question is: maybe this will end request CT will still receive. I would say, I don't know, Luis, what do you think? But of course.
No, I'm sorry, I had a problem with could you repeat the question, please?
Yes, is this, I mean, the question is, maybe this system will hand a request for pituitary CT of the, pituitary gland, inappropriate. I mean, this will maybe a more general question and an inappropriate request.
Yes. Well, what we will see, I'm sure, that the performance that of the GPs or the GP of the referrals starting, it's about 80% in general. The experience of my channel was about 60% with orthopedic surgeons, but the last figures I saw from my channel is about 90% because the people when using the system, is learning, is being educated, and the level of inappropriate examinations is diminishing. Another thing, we are always thinking that because in America they are mostly focusing in high tech, is that we saw that the real and a clear diminishing of the number of X-ray examination, most of them nobody cares about. So the lot of inappropriate X-ray that we are performing I'm sure in all of our hospitals, that we even not referrals, even us as radiologists, we don't care too much. And there's a lot of room to improvement there.
Okay. So another question from Jan Schilbeck is asking if there are other members of other societies involved in EISRE guidelines working group. Other society, maybe is speaking about a specialty society, maybe?
Not yet. We are planning to do so, as our fellows in America did, with endorsement of different medical societies. And I think this is going to be needed because if you want the referrals to be involved in this the implementation of guidelines, we have to have them anyway. But as you saw, we are just implementing the pilots, but this is in the pipeline. We have to include and to engage them in the review of the guidelines for sure. But at the local level, you have to do that anyway.
Okay.
So my idea is for the EISRE to have a generic evidence-based guidelines that will cover 70–80% of the clinical conditions. And then some of them has to be adapted, and you have to have in your system to cover 100% of the clinical scenarios. At the MAR channel, they have that what they call clinical indications, and they cover everything. And the rest of the clinical scenarios that are not covered by the guidelines are covered by consensus or by work in the particular institution.
Okay, there is a question from Moscow. Alexei Shoshin is asking if the EISRE appropriateness criteria are available in a paper form.
Not yet.
Not yet.
Not yet, because we are working on that, because we are adapting the ones from as I said, from the appropriateness criteria. Our idea is to have this common set of guidelines in the future, global ones. And in this case, probably there will be in PDF format as the appropriateness criteria, but we don't have it yet at the EISRE level.
Okay, a question from Ida Stackelberg. Do we need approval according to medical devices law, e.g. in Germany?
Yes, we are working on that at the OSTI level. So the EU level has to be approved, and NDSC is working on that. I don't foresee any kind of problem about this.
Okay.
But we are doing it through Austria.
Okay, another question from Elmar Kotter, again from Germany. Is there any members of the Elmar asking, is there any mechanism of feedback of the value of the examination into the system, getting it self-learning, a kind of self-learning?
No. We have all of the information, and we review. Our plan is to review with getting the data, as our friends in US are doing, and to get information about the different clinical scenarios, the use and the ratings, and to learn from that. But if he's referring about deep learning or computer, from the computer point of view, no. Okay. Not at this moment.
From Zagreb, Sinisa Koshina, she's asking, who is responsible for maintenance of its content? I mean, maintenance of the software.
Oh, well, it's the The contents is responsibility of the EISRE and the ACR. In our case here in Europe, the responsibility for the contents is EISRE, are for the system integration, the development, integration, it's NDSA.
Okay, here we have a double question, I would say, from IDEB, from Dr. Stackenberg. He's asking who is responsible for the translation, and again, who is responsible for the adaptation on national guidelines?
Well, in our case, it's the institution. So if in Heidelberg, as far as I know, they will be implementing the system. It's at the institutional level. There's a contract, and the institution has to take care of this responsibility. If this
what about
is a regional level, then can be the health authorities for that. But we didn't get into this process yet. So at the moment, in my institution, the responsibility for translation and updating and the localization is from my institution.
Okay. And what about the translation? Because
it's exactly the same in our case.
Exactly the same. Okay.
Yeah.
Eric again is asking: Eric Ranchert, are the guidelines adapted of the hospital service, peripheral hospital versus academic? So there is a difference between peripheral hospital and academic.
Well, Eric you have to understand some cases in some community hospitals, maybe they don't have the same availability for MR or different countries that we have in our hospital, or sometimes depending on the facility you have more, or the doctors, do you prefer to high rate a bit the ultrasound compared with MR for musculoskeletal? So this kind of stuff, this has to be done and localized, not only at the institutional level, depending on the facility or depending on the setting. But this can be done very easily.
Okay.
Under the responsibility of the institution, I have to say.
Okay. So we have two final questions, I would say, because the time is almost over. One is from Villerose from AGFA. The question is, does National Decision Support Company have the exclusivity of the EISRE guidelines? So
yes.
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 Okay.
And it's the same contract that the ACR has with American College of Radiology in US. We have exactly the same kind of contract with NDSC here in Europe. So for other companies to use the system, they have to get into agreement, as it is in US with NDSC.
Okay.
For us, the more people using the system, the better. So no question about that.
Okay. So, and the final question is, if national guidelines differ from EISRE guidelines, is there a way to modify iGuide appropriately so the EISRE guidelines can be modified?
Our idea is through the existing committees, the EISRE iGuide working group at the EISRE level and at the ACR level, we will take into account all of the feedback coming from different settings, national, regional, institutional, but it's up to us, based on the evidence, to take these changes or not.
Okay.
Because we are responsible for the contents.
Okay, so I see that there is a questions about the presentation, and you can download the presentation in PDF just clicking on the box in the left side. Anyway, the presentation will be available, because it's being fully recorded, will be available on the USOMI YouTube channel. So after the webinar, within tomorrow, you will find it on the YouTube channel. You can see and record it again and store it and so on. So it's time to close the webinar, and I would like to thank Lluis Donoso for the great webinar he made. He has collected a lot of attendees and a lot of questions. So this is the sign of a great results. So thank you very much, Lluis, for for supporting also EUSOMI in this initiative. Many thanks.
Yes, I would like to thank EUSOMI and you, Professor Neri, for this initiative. I think it's a great initiative. So my thanks and congratulations for your work. A successful
Thank you very
work.
much. Okay.
And follow you that and this.
Okay. Thanks.
Hope to see most of you. I know most of you. So
yeah. Yes, because me and Lluis, we can see the attendees, so we will have the opportunity to interact with you if you wish, of course. Many thanks again, Lluis, and
thank you, Manuel.
Thank you.
Bye-bye.
And many thanks to the National Decision Support Company that has sponsored this very interesting webinar. This is the 9th webinar of the EUSOMI Society. The next webinar will be dedicated to other important issues. There will be a webinar about 3D printing and how radiologists should know, what radiologists should know about DICOM images. So very practical webinars. They are available on the website. So thank you very much again, and have a nice evening.
Okay, bye-bye.
Bye-bye.